Yes, go ahead.
Is the final at 8 a.m.?
Yes, yes, it is at 8 a.m. And that should be all arranged for you guys out there with your proctors and everything also. So 8 o'clock. We had to do that because there's another exam right after us. And so they needed the computer lab here. Okay, let's talk about those babies then, huh? Maybe you'll like those better than the moms. Okay. Okay, so when we talk about newborns, about 9% of our newborn babies are sick enough at birth that requires some type of intensive care. And we have, oh, it's not there? I apologize. Thank you, Heather. Okay, there you go. So we have the NICU, the Neonatal Intensive Care Unit, which is just like an ICU, but it's just for neonates. So up to age 28 days. So even if a baby goes home from the hospital after birth and then something happens, they would be readmitted to the NICU if there's an emergent situation, as long as it's within that 28 days. So when there's minor illnesses, the nurses can take care of those babies in the mother-baby unit, and things that are kind of normal, like phototherapy or even IV antibiotics, as long as the baby's responding, doing fine. And they call that a level 2 nursery. Your level 1 would be your community care. Level 2 is like a special care type, and that's not neonatal care. But hospitals that have NICUs have sort of gotten rid of their level 2 nurseries because it's like, well, why do we have both, you know? So therefore, they either meet absolutely everything totally normal or they go to the NICU. And there's a disadvantage of that for families because it gets costly, you know, or they may have to be transferred out of town. You know, we do have a NICU here at Aspirus. However, you know the politics of nursing and medical care. So if a baby is born at St. Clair's, for example, and requires NICU, they transfer them to Marshfield because they're going to stay within their system. Remember that parents can choose where they want to go. And as nurses, we need to just give them unbiased options and let them decide. So that neonatal care is going to give them absolute best chance of survival. When we look at our high-risk newborns, here's our long list of all the different things that we may see. So let's start with those preterm infants, and many times they're called premature, right? People also confuse them with low birth weight, that LBW is low birth weight. Not all low birth weight babies are premature. If they're premature, they're probably low birth weight, right? But not always. You could have a preterm baby who's 10 pounds, and they're definitely not low birth weight, but probably the mom was diabetic, and that's why you see that. So both preterm and low birth weight are the leading cause of infant death. So that's our very number one thing, is that preterm. And I was at the conference for Wisconsin Association for Perinatal Care last week, and they were talking about SIDS and talking about all the stuff that we're doing with safe sleep and all of that, and they still are saying that the biggest risk factor, even though some parents, and they've got the percentages of the parents that put the babies on their tummy, or the high percentage that are still bed sharing with their babies, and now that's become a bigger issue than the other parts of SIDS, but they still say the preterm baby is the biggest issue even in relation to SIDS, that they have the highest risk factors. So we still have a lot of work to do in trying to prevent preterm babies. So cause is unknown, but we know we have those risk factors. Remember, if you listen to the Camtasia lecture for high-risk perinatal, what did we say was probably the most common cause of preterm labor, which then many times goes into a preterm birth. Do you remember? Infection, yes. Some kind of infection. And do you remember from way back in second semester, what is the most common symptom that women have when they have an infection of a vaginal type or uterine or, reproductive type infection? No symptoms at all. So here you go, no symptoms at all, most common, and then that is what's causing the preterm labor. So what I'm telling you is these moms don't even realize they have an infection. And sometimes they're just, carrying it. They don't even realize they have it. That's what puts them into labor. And one of the most common infections that puts them into labor, UTIs. Remember, because of the location of where the kidneys are and the urinary tract right behind the uterus. So if you get that angry, irritable urinary tract system, it's going to cause contractions. It's going to cause that uterus to be angry and irritable. So the first thing we do when somebody comes into preterm labor, we want to try to stop it. And so we want to get a urine sample. And the other thing we do is hydrate them. Remember, dehydration can also cause preterm labor. So it's really difficult to talk about preterm infants or high-risk infants and not be thinking about what's going on with mom. Because in a high-risk situation, you have two patients. You got the mom and the baby. And hopefully there's just one baby there, but obviously there could be multiples. So prevention is the most important thing. And if you listen to anything March of Dimes has to talk about, that's their big focus. And the whole idea is adequate prenatal care and getting them in early so we can follow them and see what's going on. Okay, so as I said, most of your preterm babies are invariably low birth weight. And when we talk about preterm, we're talking about a live birth born before the 38th week of gestation. So up through the 37th week is still preterm. And remember, years ago, we worried so much about these 24-weekers, these teeny tiny little pretermers, and then they developed surfactant because they had so many respiratory problems. Then they developed surfactant, and with surfactant, they now have had really, really good results with these kids surviving. Now the kids that we are worried about the most are those late preterm. And they used to call them near term, and that gave the parents the false sense of security that, oh, well, they're almost due. And they're actually finding that that group of babies, like 36, 37 weeks, are some of the highest risk areas for problems. So also a baby that has a weight of less than 2,500 grams, which is 5 pounds, 8 ounces, is in that preterm category. Now the incidence of preterm you can see, but look at the health disparity. When we talk about health disparities, you've got a double the percent of African Americans are having preterm babies versus the Caucasian population. So there's something going on, and obviously they're focusing on looking at that. Your preterm baby accounts for that 80 to 90% of the infant mortality. So the deaths that occur in the first year, 80 to 90% of them are attributed to the pretermer. So it's a huge area. And we have the low birth weight, the very low birth weight, and the extremely very low birth weight when it comes to technical definitions of weight. I am not going to ask you that in a question that you have to figure it out, but it could say in a scenario perhaps, and I'm thinking especially more so on NCLEX, where they may say that this is an extremely low birth weight baby, and then you've got to keep that in mind as you're looking at their care. Okay, common characteristics of those pretermers. You look at them, just their appearance, they look preterm, okay? They're very frail, they're very weak, and their muscles, their muscle tone. What did we say about full-term, healthy babies? They're in that fetal position. They stay all tucked up. These kids are just laying frog-legged, very floppy. You pick up their leg. There's no resistance to you moving them, and they just have no subcu tissue at all. They're their skin is very thin, and they have what's called a ruddy appearance. They have a very red, almost shiny skin color to them, and they have that ruddiness, but also even with that red color, if you look especially over the trunk, you can see every single blood vessel. It's like that skin is so transparent. And they have no sub-Q fat, I mean very little. Think about some of those other characteristics that we talked about back in second semester in doing that gestational age assessment, like the ear cartilage. The pinna of the ear is not curved over. I always call it elephant ears. If you know what I don't mean the food, I mean the real elephants. And you know how their ear is flat. And that's what these babies' ear looks like. They will eventually develop a pinna, but when they're preterm, they don't have it. So it lays flat, and when you flip that ear forward, it stays there. And so we're looking for recoil. We want the ear to come forward and go right back. And theirs don't. And they just have very little cartilage there. Remember the creases of the hands and the feet? They have no creases at all. They're just smooth and shiny. And when you look at the genitalia, if it's a girl, the labia majora and labia minora, they're supposed to be labia majora covering the labia minora. They're both equally prominent. And the very, very and kind of spread open, and the very, very preterm baby, the clitoris is very enlarged, and you look for a split second and you think it's a boy, because it actually looks like that could be a penis, and then this labia could be the scrotum. So it's very prominent. But all of those areas are very, very prominent. And with the males, their testes are usually not descended, and very, very smooth scrotal sac with no rugae. Remember, the rugae are those little wrinkles in the scrotal sac. So you just look at those kids and you know immediately they're preterm, because first of all, that appearance. Behavior, they have no energy. They're not able to maintain their muscle tone. Their suck is very, very weak. The suck and the respiratory is the two last things to develop in your infants. They got that real feeble cry. It's not a high-pitched cry, because what would we worry about with a high-pitched cry? What? Stridor, or what else did I hear? Pain. And neuro damage. Very high-pitched cry is usually some kind of neurological damage. So you see that in those drug-addicted babies and in any baby who has a neurological problem. So high-pitched is a little different than pain. Pain is more of a screaming type cry. Stridor is a little bit more of a hoarse cry. The H-O-A-R-S-E cry. And so this is a very different, this very high-pitched tone. They just get very exhausted by noise and just your routine activities. So we say, let's cluster activities to do with them. We don't want to go in every 5 minutes, okay? But you also don't want to go in and do everything at one time, because you will exhaust them. But kind of cluster activities and do a few things together and give them some time of rest. The NICU at Aspirus has a really cool light system in the ceiling. And so if you're talking just at regular, volume, the light stays green. As soon as you start talking and projecting your voice, it goes to yellow. And when I take parents up there on tours, I'll clap my hands and it goes to red immediately. And it's a good thing for the nursing staff to watch, monitor, keep in mind, because those kids, you'll notice their O2 sats just bottom out because they get exhausted when there's activity, loud noise. They put a little quilt blanket over the top of the isolette to keep it dark. So they try to really maintain that environment to keep things calm and quiet so that they're not stressed out. And so that's kind of a nice reminder, because you get the physician, the nurse, the respiratory therapist, and maybe the parent there, and you're all just talking at regular volume, and all of a sudden it's too loud for that baby. So it's kind of a nice thing. And at Aspirus, have any of you been to the NICU, seen the NICU? Okay, so a couple of you have. see if you can get a tour sometime, but they have single room NICU care. So you know how most ICUs, you have your desk in the middle and all the beds around it, and most of the NICUs are designed that way too. But they have each specific private room for the baby, and they've got a little area for the families to stay. Yes, yes. And they have that twin room actually connects to another room so that they could accommodate triplets, kind of like adjoining rooms in a hotel, that kind of thing. So, but yeah, they've got, so it's set up very, very nice for, they are finding better outcomes with those single rooms because less noise, less distraction, less interruptions by all the other machines, beeping and stuff. And that's another thing, they've turned the alarms down, but the nurses are right there. It's a one-to-one situation. Just keep in mind that your preterm babies, if they are not supposed to be born yet, think about them, think about that turkey in the oven. It's not quite cooked yet, okay? So that means all body systems, all body processes are at risk for not being fully functioning. So we have to look at everything. But the two last things to develop are suck and respiratory. So we worry about their breathing. That's why they developed the surfactant, which helped immensely, and then we worry about their feeding. And many times they're not strong enough to go to breast. That takes a little bit more effort, and so we work at getting them to be able to eat, and many times they cannot take it by mouth yet. They will have a feeding tube, and then they monitor how they're doing, but when they do start sucking, just that work of having to suck, swallow, breathe can be tremendous, and their O2 sats will drop. So we watch them just so carefully. So, yes. No, that's okay, Amanda. Yes, good question, because in the NICU we consider breast milk liquid gold, because the research has shown that those babies, if they get their mom's milk or milk banked milk, so Wausau Hospital is part of a milk banking system, they will do better. They'll recover faster, like maybe half of the time needed in the NICU when they're getting mother's milk, breast milk. So that's really important. Yes, they will always give them that first, no matter what little bit they pump will go into the feeding tube. Yeah, and we've found, you guys, feeding tubes on newborns, best to go through the mouth versus the nose. And we usually don't leave them in place. We usually put them in and out each feeding, less traumatic going through the mouth and less difficulty with interrupting, or I should say interfering with their breathing. If you put it in their nose, it really interferes with their breathing and they're having trouble enough. Yes, Tracy? What did you say? How they check placement? Well, it's hard to go into the lung on a newborn. I don't know why, but you just go down, goes in the stomach, and then we, aspirate for stomach fluid. And then remember, your other way to check placement is putting the stethoscope over the stomach, put a little bit of air in there. Yeah, yeah. But you know what? In all the years that I put that feeding tube down, we use like a tiny little suction catheter, like a 5 French or an 8 French. I mean, they're very small. In all those years, I only went into the trachea once, and the second that baby starts choking and their color turns blue, almost black. It's so blue, like your uniforms. So it's noticeable right away. So you don't have to do x-ray for placement. You're thinking, if you put it in every feeding, do you have to get x-ray every feeding? No, because it just slides down real easy. So look at all the huge long list of problems with our premature babies. We have a huge list. So if you look at that thermal regulation, remember the heat loss issues that we talked about in second semester, how newborn babies, just newborns, lose heat at a much faster rate, but then your premature babies are going to lose it faster. Why? Why do you think they're going to lose it faster? They have less sub-Q fat. Yes, so that sub-Q fat is kind of an insulator They have less of it, and what do they do with their muscle tone? They're laying out. So those babies that tuck themselves up into that fetal position, they actually are decreasing their surface area, how much is exposed to the environment. But your preterm babies lay just frog-legged. What we used to do for thermoregulation when I worked both in Green Bay and here, we would use saran wrap and wrap their extremities in saran wrap to try to hold some of that heat in. And that was very, very effective. I mean, you do what you have to do to try to keep them warm. The other thing is that, remember the brown fat that we talked about, that highly vascular fat that as the blood goes through it, it warms them. They don't have enough brown fat either, so that's a problem. So they're much more likely than a full-term baby to have problems with the thermoregulation. And look at the list of things on the bottom there, the complications of heat loss that can occur. They get hypoglycemic, then they go into metabolic acidosis and the other issues there that happen. And then they're trying to use all their calories to stay warm, and so they end up with more respiratory problems and growth problems. They're just not growing and having a good weight gain because they don't have any calories left for it. So huge issue with keeping those kids warm. So you look for their you look at the actual skin temperature, you want to monitor that, but there are other signs and symptoms that tell you that they're having problems with thermoregulation. And sometimes it's weird, it's like, what does the feeding have to do with your thermoregulation? So with newborns, those symptoms don't always connect, and it's harder for you to make those connections as to what you know for adults. It's very, very different. And also that temperature instability is going to be your first sign of infection. So, and which temperature do we worry about on newborns? The elevated temperature or the low temperature? The low temperature. Newborns really don't show fevers for the first month. They just don't show fevers. It's extremely abnormal. It's just, I can count on one hand the number of times you see a fever with a newborn. They're going to have a low temp. So we worry about those low temps. And I always say anything lower than 98 axillary we want to know about, we want to intervene. You as a nurse then have to weigh the situation, and you have to try to figure out what's going on. Is this baby just cold and having trouble maintaining its temp because mom did it for that 9 months? Or is this baby sick? And so you have to try to get that baby warmed up and then see if their temperature will stay up. So you also look then for any other signs of infection. What if mom was group B strep positive and all of a sudden the baby starts showing low temps? Right. Anytime a baby gets an infection, they don't just get an infected hangnail, okay? It becomes systemic very quickly, and so we worry about meningitis. You worry about them, what we do is we culture blood, urine, and spinal fluid, because those are the three places that they're going to get it systemically, is in the urine, in the blood, and in the spinal fluid. So we do what's called a septic workup. So when that baby is showing us any signs of infection, we're going to go ahead and do a septic workup. Better to be safe than sorry, because that infection can go through them so fast. And that septic workup means lab work as well as culturing those three areas. So that means you have to do a spinal tap on that baby. Kangaroo care can be very effective too, but it depends on how sick that baby is. But we might start with that, especially with a full-term baby. And a preterm, we would try as much as possible too. Yes, mom or dad, kangaroo care. You guys know what that is. Okay. All right, so your nursing interventions. We need to maintain that neutral thermal environment for the baby. We're going to use radiant warmers or incubators, whatever we need. And you guys know that with those radiant warmers that go over the top of the baby, the heater, we're going to use that temperature skin probe that sticks onto the skin. Usually best if you put it over their liver. It seems to regulate their skin temperature better. And you set that temp, and then it will warm up when that baby cools down. It provides a big blanket of warmth around them. So they don't have to be closed inside an incubator in order to be kept warm. And then warmed blankets, warmed oxygen. Anything we're going to put on them, if it's cold, is going to make them cold. Remember when we talked in second semester about the 4 ways they lose heat: evaporation, radiation, convection, conduction. So you have to think about all those things, making sure that when they're first born, you have the warmer already warmed before you put them on that cold surface, and you put a bath blanket there covering the rails so that there's nothing anywhere near the baby that is cold. Kangaroo care, swaddling, and don't wean them to a crib until they're stable. Also, we don't want to bathe them until their temperature has stabilized. So sometimes these preterm babies don't necessarily get bathed right away. It could be well after 24 hours because that's not a priority, because you want their temperature first to be stable. And you have to be concerned about overwarming babies, because then you also have problems with their metabolic rate and their oxygen and glucose needs. So that's why you never walk away from a baby that's under a warmer unless you have the skin probe on and you have the right setting on the warmer that says that they're on skin. Because you guys remember that manual mode where that just keeps pumping out heat. Okay, hypoglycemia, another one of your complications with your preterm babies. Our normal glucose level is 40 to 60. We never worry about that top number because you rarely, I'm telling you, rarely get over 60 with any newborn baby, even a full-termer. We're just happy if they're 40. Okay, so that's our big concern. And watch for all these different signs of hypoglycemia. But if you had to pick from this list, which one is the most common symptom? First symptom. Nope. 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 Jitteriness. Jitteriness is usually your first symptom, the most common. You can see any of those along with it. If you sort of ignore the jitteriness, you're going to start to see these other things. But that jitteriness is where their hands and feet will quiver. And so the first thing you want to do is check a blood sugar when you see that. Check a blood sugar. And if their blood sugar is okay, what do you think is causing that jitteriness? An immature immune system. Immature neurologic system. So sometimes they'll just have that jitteriness. But first and foremost, check a blood sugar. Most of the time it's low. Okay, so tell me, if it's low, what are we going to do? It's below 40, what would you do? How are you going to get it up? Feed them right away. Okay, that's important. Feed them right away. What will we feed them? What? What? Yes, breast milk. Okay, breast milk or formula, because both of those have protein in it, and that will take their blood sugar up a little slower and keep it up. We used to give those babies D10. You're right, sugar water. We'd give them 10% glucose in a bottle and have them drink that. And what did that do to their blood sugar? Whoa, it went way high. But what happened in about an hour? Came crashing down. It didn't stay there. So I'm not saying you would never give them glucose. You might, depending on how low it is. But most of the time, if it's that low, you're going to be giving them IV glucose, either by IV push or IV drip. And then you're going to follow it with some protein. Because isn't that what we tell adults when they have low blood sugar? Is you take some simple sugar that'll bring your blood sugar up quick, but then follow it with some protein and complex carbs. So we try to do that with the babies, and their mother's milk is absolutely the best thing. But if we had to, we would use formula. So care and management of that hypoglycemia is important. And then what would I do after that? I've got it up. It's staying up. What am I going to do now? Monitor it. Keep watching it carefully. If it dropped once, they're at risk for it to drop again, and make sure that they're feeding well. If they're a breastfeeding baby, we need to really be sure we're monitoring those feedings, that they're latching on well, that we hear swallowing, that mom hears swallowing, they've got a good suck, and if they're a bottle-fed baby, that we're monitoring how much they're taking in. So we want to keep them and prevent that from happening again. Okay, fluid and electrolyte imbalance is very common in our preterms because they lose fluid so easily just through the fact that they are breathing faster usually. They're using more oxygen, so you've got those insensible water losses. Their skin is more permeable. That means there's holes, right? So it's going to leak out, and they're not flexed and all those other things. Also, slow development of the kidneys before 35 weeks, so that causes issues with their fluids and electrolytes. So they're very, very fragile when it comes to fluid and electrolyte balance. So many times these kids are going to be on strict I&O. How do you think we do that? How do we measure strict I&O? Weigh the diapers. So that's the best thing. We can see how much they're taking in. They're probably on IVs. We can see how much they're taking in. We can measure that. But how would we measure their diapers? We'd weigh them. What kind of a scale do we use? A gram scale. So that's that old-fashioned kind, you know, with the balance on it, that gram scale. And you have to weigh your diaper first, so you know how much those diapers weigh. And then you're going to, for every gram, that's 1 ounce. Excuse me, 1 milliliter. For every gram is 1 milliliter. So we can keep a very close measurement of that. So monitor accurate I&O. When we're talking about I&O, don't forget about any of the tube feedings, oral feedings. Output, the most thing that people forget is blood draws. They're having lots and lots of labs. We've got to be very conservative with how much blood you remove because we have to replace all of that. So be sure you monitor those blood draws and watch for signs of dehydration and overhydration. And we usually can measure specific gravity right at the bedside, so we can keep an eye on that. So your nursing interventions, carefully regulate their IV fluids, usually 1 milliliter per hour or less. So remember, we said when you're administering IV fluids, you can cause overload real quickly on the very old and the very young. So here's your very young. We want to be very careful. Don't over dilute their IV meds because then you're giving them too many fluids. And always restrain them during IVs because they can pull that out and infiltrate so quickly, and then you've got extra fluids on board that they, you know, kind of think of them as fluid restrictions in a way. They need extra, but they also don't need, you know, more than they should. And then we may use blood transfusions if we need to replace their blood volume. So we use arm boards for those babies. We love the IVs in the head, but parents don't like those because then you often have to shave a little bit of the hair. And so we usually use the foot, the scaphoid vein is the really, really good one on the babies on the outside of the ankle, and then anything in the arm that we can get. Sometimes they will have an umbilical line. So remember that when they are just born, that umbilical cord is still moist. You cut it, and you know they clamp it and all of that, and then when we get ready to do an IV, if we can't find a site, they can actually just kind of slice off the top of that umbilical cord, and you can see right down into those vessels, and they can put a catheter in, which is going to be almost like a PICC line, a very, very long catheter that they would put in. Sometimes they'll put in one in the artery. Remember, there's what? How many arteries? How many veins? 2 arteries, 1 vein. So sometimes they'll put one in an artery to monitor arterial blood gases, but then they would put one in the vein to actually give IV meds through the vein. So if we still have that available, that's kind of like the best and fastest way to get in IV fluids. Okay, respiratory distress. This is one of our major concerns with our premature infants because of their immature lungs, and the pathophysiology here is that they don't have enough surfactant, and that's why with that introduction of surfactant, remember that's your soap sudsy lubricant that keeps the alveoli open. The other thing that we'll do is if we cannot stop mom in preterm labor, they're going to give her betamethasone IM, and that's a corticosteroid, and that for some reason helps to mature the baby's lungs. So that preterm baby is going to help those lungs mature faster, and we would like to give that to her at least 24 hours before she delivers. Now there's something else that causes the baby's lungs to mature, and that is the stress the baby's going through. So any kind of stress, like preterm labor is a stress, infection's a stress. It's almost like nature's way of trying to hurry up and get this baby, cooked, if you will, to be able to sustain life outside. And so any kind of stress does help to mature those lungs too. So we have that on our side, which is good. So what do you see with respiratory distress? We talked about this in second semester. Remember the tachypnea, rapid respirations, greater than what? Greater than 60. Anything greater than 60. And it's a rule of thumb, you guys, anything greater than 60, we do not feed that baby by mouth. That's too stressful. They cannot breathe and suck at the same time. So if they need to be fed, it has to be by tube feeding. Nasal flaring, where the nares will flare out. And remember those retractions where the chest caves in, and it could be at the sternum or intercostal. And they'll have that grunting, where when they breathe, it's a But remember how sometimes they'll start out really kind of cute sounding, where it's a and the parents think it's so cute, but you note that it's with every respiration. So it's not that baby just cooing, it's a grunt that's starting, and it's going to get worse, and it's going to get louder if you don't do something about it. Very labored breathing, and then they'll have periods of apnea. Now, 15 seconds, babies normally have what's called periodic breathing and can have apnea up to 15 seconds. We're talking about worse than that, okay? Well, I mean, I should say more, more than that. Okay, so we can give them the surfactant replacement, and that is given through the ET tube. So they'll put an endotracheal tube down, and they literally just squirt the surfactant in. But the key is turning baby from side to side so that you get it down into all the bronchioles. And it's very expensive, and its shelf life is very short. So unless you have a NICU, you don't really have that capability to keep it on hand. You're just not going to use it. Invariably, we would see our neonatal, before we had a NICU in Wausau, Marshfield would come to get our babies, and we'd have this baby that was really, really sick and really tugging and really having problems breathing, and they'd give him one dose of surfactant, and then they'd fly away with them, and we would call, and how are they doing? Oh, they're in room air, they're doing fine. We're like, we need some of that surfactant. Let's just give it them here, and they don't have to go away, And that's when we found out how expensive it is, and you just don't use it up enough because you don't have enough babies who need it, so the shelf life would expire. One dose of surfactant is usually all that is needed, and those kids are just like amazingly better. Then we focus on them feeding and growing and all of that. Now, when you've got respiratory issues with these preterm babies, you're not the only person taking care of them. You usually have a respiratory therapist right alongside you, especially if they need a ventilator, where they've got the ET tube and they have the breathing machine, the ventilator breathing for them. They'll monitor and manage that technical equipment. So positioning the baby, this is one time that it's totally appropriate to put them on their tummy or even on their side. Remember, this back to sleep issue about SIDS prevention is normal, healthy newborns who are left unattended and sleeping on their own. These babies are sick, preterm babies that are never alone. The nurse is always there or watching them on the monitor, watching their, respiratory status, heart rate on the monitor. So we have to be sure we educate parents because they're going to do what we do. They're going to see that and they'll be like, oh, the nurses put them on their tummy. So we have to say, we're putting them on their tummy because they will breathe better, and this is while they're here in the NICU and we're right with them. But that at home you cannot do that. Okay, and then hydration because their skin, we suction them, etc. Okay, one of the issues that can be a huge complication with your preterm babies is called bronchopulmonary dysplasia. Unfortunately, what those preterm babies need if they're having respiratory distress is what? What's the treatment? Respiratory problems, breathing problems, O2. So you're going to give them oxygen, give them as much as they need to keep their O2 sats up, all right? Do we want their O2 sats to be at 100? Okay, why not? Because we don't know, we can't go higher than 100, right? But say I'm giving that baby 40% O2 and they're at 100% sat. What if I drop their O2 down to 38% and they're still at 100% sat? What if I drop it down to 36? They're still at 100% sat. I only want to give them what they need. I don't want to give them too much. So our ideal goal is 99% for their O2 sat, because then you know you're not giving them more than they need. Because maybe they only need 35%, they don't need 40. And the reason for that is this complication, because they actually get damage to their lungs by the treatment that they need, the O2 that they need. It's a chronic condition that they get this damage to their lungs from the oxygen and the ventilators. So these are the signs and symptoms you see with them, which are kind of the same signs and symptoms you see with respiratory distress, so it's very confusing. But the problems persist, and they will need treatment for sometimes up to a year with this BPD. They call it bronchopulmonary dysplasia. So this is one of the big complications we worry about. It's treated with oxygen, but also with some of these medications. I'm not going to put any questions in about BPD specifically, so it's just more FYI for you, but just keep in mind about that big issue with oxygen, that you're trying to prevent complications. The prognosis is good, but for up to 3 years of age, they can have growth restrictions because of it. So eventually, they do grow out of it, but it can be a big issue. The other thing, and I don't know if it's even in the slides, is the problems with the retina. They can get retinal damage from too much oxygen, and therefore they can have blindness. So there's the other big reason we don't want to overdo the oxygen. Now the intraventricular hemorrhage occurs because you've got tiny, tiny, fragile blood vessels in this baby's brain, in the baby's head. And how are they born? Through the birth canal. The head coming down through the birth canal. So what could be just a normal vaginal delivery for a full-term baby becomes traumatic for this pretermer, and they have a brain bleed. And you diagnose that on CAT scan. And look at your signs and symptoms. They're very lethargic, poor muscle tone. Their respiratory status is deteriorating despite the fact that you're treating them with O2. So they'll have more cyanosis, more apnea, hematocrit levels drop, their reflexes become decreased, and you'll see a bulging fontanelle, and they eventually have seizures because of the bleeding that's going on in the brain. But some of these infants show no signs at all. So it's kind of a routine to just do a CAT scan to monitor for the possibility with these really tiny ones. So sometimes the physician makes a decision, we're going to do a C-section even though there's no other reason for it, just to kind of protect this baby from the trauma of a vaginal delivery. Oh, and look at your nursing interventions. We're always the eyes and ears of the physician, so our very, very important assessments, monitoring them so carefully. When you're with them at the bedside so many hours, you can kind of be that person to go, oh, there's something not right with this baby. This baby hasn't been, acting like this before. And then measuring head circumference every day and looking at any neurostatus change, realizing they could be very, very subtle. And obviously parents, because this could have some long-term neurological problems, they're going to need lots and lots and lots of support. Here's that retinopathy of prematurity, the damage to the immature blood vessels from too much oxygen, and so you can have blindness. The very, very tiny ones, the less than 1,500 grams, are the ones who are more likely to it. They don't know for sure, but there does seem to be that link to high levels of oxygen longer than what they would need. They can do some surgeries. They're being more successful with that now than they were before. So always assess the pulse oximeter level, and if you're seeing it at 100, normally in those NICUs or even in a special care nursery, you have standing orders that you can monitor and decrease or increase as needed. So as soon as you see your pulse ox at 100, drop that O2 down just a little bit and see if they can maintain it at 99. Oh, neck. Necrotizing enterocolitis. This is a serious inflammatory condition of their intestinal tract. Unfortunately, it's very common, very, very common. And it can lead to cellular death of areas of the intestines. So what's going on is that they have just this very, very weak intestinal tissue, and then they have that decreased O2. So when you start to feed them, you've got this increase in pressure, and that stress allows the bacteria to invade or damage the intestinal wall. And so if we think of necrotizing, what do you think? Like if you see somebody's toes that are, you've got necrotized toes, you've got that tissue death. And so that's what happens in their bowel. And sometimes they actually have to have surgery to have it removed. But you'll start to see nausea and vomiting. Usually they're vomiting green fluid. They're very poor feeders. You start to see their abdomens distending. They get bloated, and they might even have redness of the abdomen. So this is the one complication that one of the biggies that they worry about so much because it's more common. And so we don't like to see that. Your preterm babies obviously have nutritional issues because we said that's one of the last things to develop, feeding tolerance, etc. So we always are assessing for residual and assess them for when they're ready to start nipple feedings. Look at that respiratory rate. Okay, so it has to be at least below 60 and that they can tolerate it with all the other issues going on. Problems with their skin, obviously, and these are the kids, that thin, transparent skin. These are the kids who have all these tubes, all the IVs, and maybe the ET tube, so they're using lots of tape on them, and their skin is so fragile, you take the tape away and there comes the skin right with it. So the different medical companies are working really hard to develop more gentler things that are still secure, that hold in the ET tube, and they've done some great work on that. But you don't want to use skin prep. You guys know what skin prep is. Makes the skin stickier. You don't want to use that on them. You don't want to use alcohol. Those things are just so harsh. And sometimes these babies are so fragile when they're under 32 weeks, they actually bathe them with sterile water to try to keep the bacterial level down. And pressure points when you're positioning them is important too. We talked about the infection issues, and that's why we're so careful about hand washing, infection control issues with our babies. And then our NICU babies can have problems with pain. We used to think that they didn't experience pain, but they know that's not true. So when they have a circumcision, they do a regional block, and with some of these other painful procedures, they may medicate them also. So we'll see their heart rates, their blood pressures change dramatically, their O2 sats, when they're having painful procedures. and they have repeated exposure to pain. So we have to watch for those outward effects. So try to prepare them for those painful procedures. You know, you can't, yes, we can explain to them, can't we, but they're not going to understand. But very gently wake them up, you know, kind of, you know, very easily ease them away. One of the things we know is that if you keep their extremities close to their body, they will do better. They feel secure. So you guys know about those little sleep sacks that they have for the babies. That's why they encourage them to have their arms at their side. Some babies like them out so they can suck on their fingers or whatever, so it depends on the baby. But keeping their extremities near their body can be helpful. The sucrose on a pacifier, that is amazing. When they do the circumcisions, they use the Sweet Ease. It's one of the brands that they use, and they'll suck, just the sucking. Remember Dr. Harvey Karp and the 5 S's we talked about? That suck, swaddle, swing, shushing, and sideline that help with pain. So the sucking on the pacifier, but then also the sucrose. Talk very softly to them, cuddle them, hold them, rock them before the procedure, after the procedure, and then we do have things we can give them. They use NSAIDs. The fentanyl patch can be tolerated very well by the preterm infants. They can use some sedatives when they're really agitated. So we do what we have to. We talked about their environmental stress issues already, so try to group your activities into small groups of activities. So you don't do everything at once, but you also don't want to go in all the time. Reduce the stimuli, rest, all of those things. Individualize their care. Okay, that's the biggest issues with our high-risk babies is preterm. Okay, lots of issues with the pretermers, but don't forget about your post-term babies. Do you guys need a break? Okay, let's take a 10-minute break, and then we'll finish up these slides. Steve? I could see it fine. I could see it fine.